Bismillahir Rahmanir Rahim. Thanks to the organizers for giving me a chance to talk about the challenges in establishing a liver transplant unit in this surgical meeting. Uh, there are a lot of challenges which you can face in establishing a liver transplant unit, um, and it is variable in government sector and in the private sector. So I take pride and honor to say that me and my team was one of the pioneer in establishing a liver transplant unit in Pakistan. And this dates back to 2010-11, when me and my friend Dr. Tariq, we were called from abroad to establish a liver transplant unit in the government sector. Uh, I will briefly talk about the difficulties and challenges which we encountered during this whole endeavor, and I will talk about background, disease burden in Pakistan, difficulties, challenges faced, and the future goals which we put together. And now we are a fully functioning liver transplant unit in Pakistan. Firstly, talking about the disease burden. Uh, about the liver disease, it's a population of around 210 to 220 million people, and majority of the people facing liver disease are suffering from hepatitis B and C. Few of the patients have also suffered from NAFLD and NASH, which is becoming increasingly common. Approximately 1 million people, they get end stage liver disease, and over 1100 people require liver transplant every year. Liver transplant is the only effective treatment for end stage liver disease. Again, in Pakistan, people die of liver disease more than terrorism every day. People say there is a lot of terrorism going on in Pakistan, but if we analyze the data available in our registry or in our healthcare, the people die of liver disease more than terrorism. And Pakistan carries one of the most world highest burden of end stage liver disease, leading on to a kind of causing mortality of these patients due to liver failure. And hepatocellular carcinoma is increasing in these patients and requiring liver transplants. 10 million people in Pakistan are presumed to be infected with hepatitis C virus. And according to WHO, Pakistan carries a second position in terms of prevalence of hepatitis C after after Egypt. And there are approximately 1 million people who are chronic carriers of hepatitis C, and 1.7 billion people who are chronic carriers for hepatitis C in Pakistan. It will be a little bit unfair to talk about liver transplant without talking about the father who started the liver transplantation services in the world, and that is Professor Thomas E. Starzl, who started liver transplantation in states, started in somewhere in 1963. Few initial attempts were unsuccessful, started with the pediatrics, and now where we are dealing with the living donor liver transplants, and it's a life-saving procedure. And there are a few advances on the immunosuppression side and on organ preservation. Along with that, obviously, there are modification and improvement in the surgical skills and ICU setup as well. So if we talk about the liver transplant evolution in Europe, it started somewhere in 75, and where I was trained in Ireland, and that center started in somewhere in 1993. And whole of this, if we see the initial starting 75, and what happened after like 86, 87 in the late 80s, the immunosuppression came in, and now with the modified immunosuppression, the life expectancy of these patients and the graft survival has tremendously changed the outlook of the liver transplantation services. Obviously, in Europe and the States, the majority of the patients having liver transplantation, they are cadaver based. But in our part of the world, where the cadaver organs are not available, we are dealing with the organ shortages, and that led us on to converting this technique into living donor liver transplantation. And India, Korea, Pakistan, we are performing majority of the liver transplantation as living donor liver transplant. Talking about cadaver liver transplants, there are heart beating, non-heart beating, complete livers, split livers. So there is a huge variety of these things. I will say, me and my team, again, we are the pioneers in doing a cadaver liver transplantation in Pakistan. There is only one transplant performed so far, and that is where we started and we performed it in Sheikh Zayed Hospital. The recipient was Amir. The donor was an unfortunate guy, a 16 years old chap who was bringing his mother to the hospital, had a rotific accident, sustained head injury, and he was declared brain dead. And we performed the only cadaver liver transplant ever in the history of Pakistan. And that was on 12th of August 2011. This is a beautiful chap who was the donor, and this was the recipient. This was the explanted liver, which we removed from Amir Raza, the recipient, and this was a beautiful liver after implantation in the recipient. So this was the team which made the history in the liver transplant. Talking about living donor liver transplants, we are doing right lobes, left lobes. But there are advantages that it is readily available. There is a strong net family systems, and there is no hesitancy in donating the organs. Less ethical and religious issues, but there are religious issues, and we are trying to sensitize the people of Pakistan to come forward for donation of the organs. This is what we do is in the living donor liver transplant, we remove half of the liver and implant it into the recipient. Obviously, with liver transplant, there are few issues involved. And the main issue is the cost of liver transplant in Pakistan. I would say this is falling somewhere between 4 to 6 million, and the limitation is lack of finances. People belong to low socioeconomic status, majority of the people, I would say, and they don't have these finances to undergo liver transplant. And there's lack of awareness for organ donation, which we are working on this sector. And government is coming forward and launching a huge program. I will come in my later slides and give you the updates. Improper infrastructures in the public sectors to perform this kind of major surgery, lack of trained staff, and only few currently available working centers despite of huge disease burden. The challenge is, the crux of the whole meeting is in this slide. Um, uh, this is the availability of highly skilled manpower. When me and my colleague came to Pakistan, there was absolutely no person available who has worked in this specialty and was not readily available to kind of come together and participate in this program. So we have to work day and night to kind of train the people. We had to send our nursing staff, our doctors abroad, and like in India, Korea, King's Hospital, to train them and get these manpower trained and up to the mark to deliver liver transplantation services in our local setup. Again, the dedicated operation theaters. I will kind of very briefly touch these. Dedicated operation theaters, these were not available. And even the people who were designing the program before we were hired for this program, they had no clue what are the requirements of a liver transplant theater where we have to operate. These have to be absolutely infection free and clean theaters with a laminar flow. Uh, so that was not readily available. So we had to talk to the competent authorities and to the governments and try to persuade them, give them the examples. But the competent authorities had to visit abroad and see what are the requirements. So eventually now we are at a stage, and we are fortunate that we have the state of the art laminar flow operation theaters, twin theaters, where all the gadgetries and facilities required for the liver transplant. And again, the ICU. There has to be dedicated ICUs for these patients. You cannot put septic patients, and you cannot kind of share these ICU facilities with the other like urology, general surgery, and all that. So now we have our dedicated ICU facility. I will give you a little bit of input regarding our theaters and few pictures as well down the line. So equipments and instruments, there are specific instruments and gadgetries which are required for this, like liver cutting machines, special retractors, microsurgical instruments, special tables with the modifications and all that. So now this was another challenge, and it was very difficult to get it in a government sector. talking to the government because they are very expensive. More centers, we have kind of now government is sensitized to this issue with the disease burden available and prevalent in Pakistan. Government has a kind of done a lot of work in this area, and now there are other government sector hospitals and a dedicated hospital facility even in Lahore. They have made it like PKLI, and they are starting the service for the people of Pakistan, and even the Sindh government is providing this facility as well. Obviously, more centers are required, and is the need of the hour to further help the people of Pakistan to get rid of this killing disease, which is the end-stage liver disease. Again, the financial support for the patients. Yes, in a country which is financially drained already, it is very difficult to provide millions of rupees for the treatment of one person rather than treating other hundreds of people, which require a kind of a lot more, I would say, less financial support to get rid of disease rather than going and supporting one patient for liver transplant. So government is already supporting, and they are geared up to provide more financial support to the people of Pakistan. Structured training programs, yes, we have made a lot of effort and gained a lot of ground in this. We are training our junior surgeons, and I will tell you in later slides that we have got a level 4 training program approved by the University of Health Sciences, and we are starting MS in HPV and liver transplant. Cadaver transplant programs, again, I would say again, it has to be with the a lot of push is required from the government and from the IT sector, and the program is being launched. The talks have been delivered in our universities, our schools, sensitize the people by our religious scholars, and we are working on the cadaver program. And very shortly, you will hear that the government of Pakistan and specifically the government of Punjab is launching a cadaver program, and we will be having this facility available in Pakistan. Talking about liver donor, liver transplant in Sheikh Zayed Hospital, I'll briefly share the data which we have. These are the kind of patients which we encounter day in, day out in our OPDs requiring liver transplants, like malnourished, just like a bone of a skeleton person who has got a distended belly full of ascites, 10 to 15 liters of ascites, and they are facing huge difficulties in getting the healthcare which they require and want to continue their normal life, and that is the liver transplantation. So we have built this team, surgical team. We have at least 6 surgeons available, and they are fully trained. The donor team and the recipient team, we work in different theaters, and then once the harvesting is being done, then we work together and do the implantation. The hepatology team, once we do the finish the transplant, then this patient is being handed over to the ICU team and the hepatology team, and they look after the patient from there on. Obviously, the surgical input is there as and when required to our patient. So intervention radiology services are also where we are fortunate to have a top of the notch intervention radiologists if we need to have some sort of intervention in our patient. We have the fully trained staff. The nurses and the paramedical staff now, they are fully trained, and we have a full lab backup and the blood bank backup which is required for liver transplantation services. The how do we prepare these patients? The recipient patient and the donor evaluation is being done thoroughly. We have a full pro forma, and we kind of very rigorously work them up. And after working them up, we kind of present these patients in our MDT meetings. Once the patient qualifies that, then they go to the ethical committee. Finances is being supported, either self-support, supported by the NGOs or by the government. So I will give you the analysis of our patients who have undergone surgery, that what kind of financial support did they got. So after doing all this work, and there's a lot of paperwork involved, we send the papers to OTA, Punjab Human Organ Transplantation Authority, and after getting their approval, we select a date for liver transplant. The liver transplantation, which have been total referrals, are around 2,000 patients. Transplant assessments were done. The transplant 210 transplants were done in our center. and there are good patient, around 15 patients waiting to get the liver transplant. They split regarding the etiology. Hepatitis C, around 52% of the patients, hepatitis C in 8%, and the miscellaneous were the rest. So this was the demographic split of the recipient. The mean age was 53, males and females. So male to female ratio is 5:1. And the donors which who donated their organ to their loved ones, the first cousin around 42%, brother to brother 64, and son. So you can see these are it's only donation is allowed as per the government and the boundary lines which have been set by OTA, that only the first degree relatives can be donor. Yes, if there is no availability of first degree relatives, the second degree relatives and the third degree relatives, the FRC by NADRA certificate, family relation certificate has to be in the file in order to get the suitability. And once all these paperworks and stamp papers and everything has been done, and we satisfy the ethical committee, then we can send these documents to the Human Organ Transplantation Authority in Punjab, and they give us the permission. And after completing all this paperwork, we set a date for surgery. So the patient who underwent surgery, the MELD score was between 80 and 40. Median was 17, and the majority of the patients were child class C. Few of them were child class B and A. Obviously, they were having the HCC on board. So mortalities were 19 mortalities in 210 patients. So the actual average right lobe graft volume and the estimated was, you can see there were fair accuracy, and the remnant volume was not less than 37% in our cohort. So the GRWR was like average 1.1, around 1, so we never went less than 0.8, and the GRWR, the average and the calculated were fairly accurate. In terms of the surgical time, the cold ischemia time was around 1 hour or even less. And with recently it was around 30 minutes. So average warm ischemia time was around 42 minutes, putting the anastomosis together. So surgical time for the donor was 7 hours, and the recipient time was around 14 hours on the average. And our time is fairly kind of now coming between 10 and 12 hours in our later, because if we put the initial data, the teams were not kind of very fluent and were not like gelling up together, but now our surgical time is much more less. Regarding the recipient morbidity, wound infection, the usual ones, and the pulmonary complication and bile leaks were around 24%. Hepatic outflow obstruction was 2%, and they require RHV stenting. Fungal infections in 6%, and tuberculosis reactivation in these patients around 6% of the patient. Donor morbidity was a wound infection 8%, chest infection, and bile leaks, and they were all conservatively managed, and they went home. 1 year survival on the follow-up is around 90%, and 3 year survival is 82%. So financial support in 210 patients, self-finance was 36 patients, government finance, obviously you can see, was two-third, 149 patients, and NGO supported or company supported was 25 people. So this is our theater team working during the transplant. Few pictures. So this is just the after the harvesting, the remnant graft left. You can see the vena cava, and where the forceps is there is the main portal vein. This is the new MHV we are just reconstructing, and we have learned this technique from the Indians, not to use the Dacron or PTFE, because there are more chances of thrombosis. Obviously, few centers are doing it, but in our setup and in our settings, we kind of use the portal vein from the native portal vein and harvest it and implant it to the draining segments 5 and 8 and construct a new MHV. So if I summarize my whole talk, and these are the problems which we faced: equipments, obviously gadget specific instruments were required, the hospital premises, new theaters had to be made, and the ICU setup had to be, and the had to be up to the mark, the fully trained staff, the training programs are in order. So these were the bottlenecks which we faced. The future goals, the development of new efficient centers in every province of Pakistan. Obviously, a lot more work needs to be done, a lot more center needs to be set up in place. So government is working on it. Proper training centers and programs already running, set up, training junior surgeons and all healthcare providers, and awareness programs and campaigns and more symposium needs to be done. So a big success for our unit. We have started a level 4 training program. I would say this is the first program in whole Pakistan, level 4 program for this specialty, like MS in HPB and liver transplant surgery. And we are inshallah going to recruit our junior surgeons after this for a second fellowship or a second training program. They should be like fully they should have had their have CVS program, and now we are going to recruit and give them a second degree which would be acknowledged, and this is acknowledged by University of Health Sciences, accredited by them, and Pakistan Medical, this PMC has also validated our program as well. So in summary, this slide shows that we have limited resources, a lot of disease burden in Pakistan, and there are a lot more many people which require liver transplant, and they are dying due to lack of finances, lack of donors, lack of facility available at their doorstep and in their towns and in their province. So we are trying to kind of do this titanic job, and so far so good. We are thank to Almighty Allah that we have saved few lives, and a lot more surgeons, centers, resources needs to be put in, and we will be able to rescue our people, and they don't need to go abroad. Now we have Alhamdulillah work 2 centers in Lahore, 1 center in Sindh. They are providing facility to the people of Pakistan. This is our team who had made it possible to save these lives, and few of these team has left us, got retired, but now we have a fully fledged functional liver transplant team available in Lahore, and providing services in Sheikh Zayed Hospital. So thank you very much for listening to my talk, and all the best to the organizers, and thanks for giving us this podium. God bless you all.